very, very exciting. So today we're going to do our SBD Virtual Journal Club, and we have some very, very exciting journal articles to discuss tonight. So I'm going to hand it over to Dr. Katie Sue, who's going to introduce our first speaker.
Thank you. It's my pleasure to extend a very warm welcome to our first speaker this evening, Dr. Amy Paller, who obviously needs no introduction to this group. Dr. Paller is professor and chair of dermatology at Northwestern Feinberg School of Medicine. She has authored hundreds of peer-reviewed publications, served as president of multiple organizations, including the Society for Pediatric Dermatology, and she has played a key role in shaping the field of pediatric dermatology. Dr. Paller will be presenting her recent publication entitled Stigmatization and Mental Health Impact of Chronic Pediatric Skin Disorders from JAMA Dermatology. Welcome, Dr. Paller, and thank you so much for participating in tonight's Journal Club.
Thank you so much, Katie. What a nice introduction. I will say, though, that this is not my publication. This is our publication. And I'm going to now share my screen. All right, hopefully everybody can see. I'm going to be chatting a little bit about the article that we all published in JAMA Dermatology based on our big PEDRA study. And just a little word about how that came about, because it was several years ago. Several of us were talking to industry and trying to encourage them to develop new medications for children with chronic skin diseases. And we had some pushback. It was that they didn't think some of our diseases were important enough. And we couldn't believe what we heard. We said, but they have such a dramatic impact on the children that we serve. And they said, well, then provide us with some quantitative data to support your contention about that impact on psychosocial health. And that's what we set out to do. Our hypothesis was that skin disorders in children, especially those that had higher visibility and greater severity, would impact the social and mental health of school-age children. And the hope was that that would highlight the need for safe and effective therapeutics for their treatment. Now, we had an opportunity that we took advantage of because there was a new tool that specifically would measure not just generic stigma in general, but actually with 6 items that were skin specific. And then, of course, a variety of other PROMIS tools that really hadn't been used much in dermatology, let alone in pediatric dermatology. And PROMIS stands for Patient Reported Outcome Measurement Instrumentation System. It's a group of tools that have been developed over time by NIH funding, and they're freely available and all calibrated nicely, usually to the general population. Our primary endpoint in the study was to correlate the extent of stigma with the child's perceived disease visibility. But we had a number of secondary endpoints as well that would measure various parameters and then correlate the extent of the child's reported stigma with anything from the child's assessment of severity, the parental responses about stigma, child's assessment of anxiety, depression, peer relations, quality of life, and several other assessments. It was quite a study. 32 centers enrolled subjects, and I'm sure many of you out there were involved in this study, and I want to thank you because it really was a group effort. We started in November 2018, and we ended in June 2021. And something came up in between those dates that was a problem, and that, of course, was the COVID pandemic. And we didn't really know how to handle this because here we were looking at mental health issues and trying to look at stigma of children, knowing that it was predominantly in the school setting, and yet kids were out of school and there might have been other changes. So we had several meetings, including with some of the supporters who were patient support groups, and decided that we would take a pause. And we did from March until August 2020. And at that point, kids were going back into the schools, and we were able to restart the study. Now, the inclusion was subjects 8 to 17 years of age. They had to be diagnosed with a chronic skin disease that was deemed severe enough and or an invisible location, and there were numbers to go with that could be stigmatizing as determined by the study doctor. You can see other criteria, but I will say an exclusion was a non-cutaneous disorder considered potentially stigmatizing by the study doctor. So, for example, a child who was obese, we didn't want to enroll that child and consider other confounders. There were altogether 671 children and adolescents surveyed. I'm showing you some of the parameters based on age, a little bit majority female, highly visible at all times in the majority of the child reports, and moderate for the majority, barely the majority, about half, based on the child report. I also want to note that there was a little bit more of this high visibility or in this moderate category who were in the adolescent age group, but it wasn't terribly different. And I also want to point out that 29.4% of parents knew about bullying. That didn't mean that the children beyond that weren't bullied, but the parents knew about the bullying. A little bit about the age range here over on the right. You can see that even though the adolescent ages were fewer, there were about half of the kids who were in that adolescent age range altogether. And then if you look down on the left, you can see that, not surprisingly, most commonly we had acne and atopic dermatitis, alopecia areata, and psoriasis. But you can look down the list and see that even some of the rarer diseases are represented here. Now, just a word about promise tools so you understand, because I know most are not familiar with these. These are generated with questions that have been individually calibrated. So you can have all the questions in a toolbox. You can have just 6 or 8 of them that are put together as short forms, or even use them on a computer where you can have even fewer in there, have meaningful results, because every one of these questions is individually calibrated. It doesn't matter what you use. That's one point. Another is that you get a raw score from it, and then you can just change that into what's called a T-score. And the T-score normalizes it to the population that was studied. So most of these promise tools have been calibrated against the general population. So that means the vast majority of the kids will fall between 40 and 60. And for most of these, it's 40 to 55 is just right there in the middle. We don't even think about it if it's below 40 and certainly below 30. 55 to 60 is mild. And then above 60, you get into what you really should be concerned about, the high or moderate, and then the very high or severe going above 70. Now, the stigma tool is different. It's one of the few promise tools that was not normalized to a general population. It was normalized to a population with chronic diseases. So not just skin diseases, but neurologic diseases, cancer. And therefore, the mean, what's in the middle, is kids with chronic diseases who probably have some degree of stigmatization. And it was worked out here that everything would be shifted over. So if you have 40 to 45, less than 45, it's mild. You get into that high moderate range at 45 to less than 55, and then above that is quite a bit of stigma. So where did our patients with chronic disease fall? Well, you can look overall in the upper left-hand corner there and see that 73% had at least mild stigma, if we think about that 40 to less than 45 being mild and then everything else being above that. Now, the mean for that group overall was in that mild range. But we had several diseases that were really having a mean in the moderate range, and these included ichthyosis, hidradenitis suppurativa, hyperhidrosis, and EB. And some of these were kind of interesting, like hyperhidrosis is hugely stigmatizing compared to some of these others. And hidradenitis suppurativa too, where I'll tell you in just a minute where it landed. So if you go back to that overall, you can see that almost 44% had moderate stigma and 8.2% had severe stigma. And more than 10% with severe stigma were seen in ichthyosis, EB, hyperhidrosis, and atopic dermatitis. We also divided the stigma questions based on whether they were internalized, that is what a person thought themselves. For example, the way that they felt like they were being stigmatized or singled out, as opposed to experienced, where there was something done to them, like somebody was mean to them. That would be an experienced or external stigma. And what we did is, with 11 of the 22 questions being internalized and 11 of them being experienced, we were able to divide. And it turns out that really almost all, I think the only one was vitiligo, that had about equal numbers of internalized and experienced. And almost all of them were more so scoring more highly on internalized. So maybe they start out with more how they're being teased and the experience, but they internalize it. So chronically, they're feeling this perceived stigma. And this was especially true of two diseases which may not surprise you. One, the hidradenitis suppurativa, and the other, the hyperhidrosis. And you can see the numbers here, quite separate in terms of the internalized versus the experience. We were able to show that the stigma differentiated the levels of visibility, as shown on the left, and severity, with very significant p-values. And notice at the bottom how these were divided. So the child would decide very visible, barely covered by clothing, not visible, mild, moderate, severe. So what about some of the characteristics? The Skindex teen score, which unfortunately doesn't have strata like the CDLQI, ended up like this, which we decided was probably the moderate impact on quality of life. The PROMIS depression score showed that 14.3% had at least a moderate or high score. And interestingly, even though it was overall 14.3%, hyperhidrosis and hidradenitis suppurativa had really high depression scores. So 41% hyperhidrosis, 44% for hidradenitis suppurativa. And I thought it was also interesting then to look at correlations of these high depression scores with stigma. The depression, for whatever reason, in hyperhidrosis does not have to do with stigma, but on the other hand, very strongly correlated here with the hidradenitis suppurativa with stigma. So depression and stigma, suggesting that stigma is very important in the depression that's occurring in hidradenitis suppurativa. Anxiety score 14.5% with high scores, and peer relationship 28% with a high score. And notice that I say here less than 40, because some of these PROMIS tools, it flips the other way. It's an inverse relationship. And so that's why we say less than or equal to 40. And then finally, look at the paper if you want to get more information here, but I'll just tell you that the highest correlations with stigma were bullying and poor quality of life. There was a strong correlation with depression of stigma, and moderate with anxiety and poor peer relationships. Even though I told you it's nicely divided out, the mild, moderate, and severe visibility and severity, it turns out that the correlations were very weak with the child's reported visibility and severity. And if you looked at the parental assessments of these, it was even a weaker correlation. How about the parent versus the child? Are the parents good reporters? Well, there is a moderate correlation of the parent's assessment with the child's of visibility and severity. But that leaves us some room and tells us again that these children who are able to answer for themselves, who are 8 and above, are able to assess and perhaps better assess their view of visibility and severity. But I will tell you that the MD assessments correlated very poorly, both with the child and the parental assessments. So we need to ask. So in conclusion, I don't want to spend any more time. I'll just leave this up here as we ask some questions. But I want to just reiterate that only 27% experienced no or minimal stigma in this group. And that because the parent and child scores don't strongly correlate, we may want to capture the child. And there are short 8-item short forms available. You can do this quickly in the office in just a few minutes if you want to gather stigma or even gather stigma in some of these other mental health assessments. So where did we land? Well, I think we landed very definitively in showing that the high number of children with chronic skin disorders and stigma, which is a mental health impact, supports the need for improved therapies for children with chronic skin disease. And with that, I'm going to stop sharing and take any questions you might have.
Great. Thank you so much, Dr. Paller, for that wonderful talk and for highlighting this important PEDRA effort. Just a reminder to the group to please enter any questions that you may have in the Q&A. So I guess to get us started, Dr. Paller, I would be really interested to hear if you have any pearls when it comes to having discussions with patients and their families about how to handle bullying and how to educate others about their skin condition. Are there any particular resources that you direct families to?
Yes, there are some wonderful resources. These are tough questions because it's very hard to address. For one thing, for example, when questions came back with depression or anxiety and they were high, we made a commitment up front that we would talk to the family, that we would talk to the doctor about that. And stigma also is a hard subject because children are embarrassed. They don't want to bring even to the parents. That's why 29% here knew about bullying. It's embarrassing to them, and so bringing it up in the office is difficult. But I do think we need to, and certainly if the child is looking down at the floor and having evidence that there might be something going on with a mental health issue, it's imperative to ask. But I like to just ask, how are things going at school? Is there any problem with the way other kids are relating to you? And depending on the age, I'll talk to the child. I may talk to the parent as well at the same time, try to gather that information. In studies, obviously, we can capture this, but in a busy clinic, you may not want to take the time to do that. So I think it's just broaching, since the 90+% of bullying occurs in the school setting, I think to just kind of ask about school and are there any problems with school and any issues with other kids and how they relate to you with respect to your skin problem, I think is a gentle way to ask without having to use the word bullying or stigma, which are big words and are a little bit difficult in concept for families to know. I'm surprised how many parents will then say, actually, we've had some real issues in the school. I've had to talk to the principal. And that's the first thing, education of the environment, educating the other students, educating the teacher, the principal, upfront proactively is really very important. For children who are already being bullied, it's important to sit down with the school and have some discussions about that. American Academy of Pediatrics has some great resources about bullying. There's several others available, and I'm happy to share them. If anybody wants to know, just send me an email.
Great, thank you. I think we have time for one more question, which comes from Dr. Harlock. Asking, are there any follow-up questions for the big study, and what is the next big challenge to tackle?
Yeah, well, I think that certainly there's a lot we can take home from this, and it leads itself to the potential for doing other studies that really look at mental health and that include stigma. But I would say the biggest thing for me in terms of low-hanging fruit next step was to take some of these that had smaller numbers with, for example, I'm just going to go back for a second, give you some real numbers here. But the hidradenitis suppurativa had 22 patients. And we see this all the time. And some of the rarer diseases like EB with 16 patients and ichthyosis, we had quite significant data despite these small numbers. But I think that it really behooves us to go into patient populations and now focus on some of these where we didn't feel like we had large numbers and verify that what we saw is real and get a little bit more. I think the PEDRA acne hidradenitis suppurativa group is already moving forward with another study to try to follow up on this. And we've been collecting ichthyosis and EB data at patient conferences, and we'll be reporting on some of those. But this is the kind of thing we need to do, is to really flesh out some of the other numbers. There were some others in here that might be quite important, but the numbers are small, like congenital nevi that are visible. We can use these kinds of tools to do a deeper dive on that, or vascular malformations.
Thank you so much. So for time reasons, we'll need to move on, but it looks like there are a couple other questions that have come in the Q&A. If you're able to answer those, that would be great, but no worries if not.
I'll see what's in the chat. I see I can access Q&A, so I will. Okay, thanks, everybody.
Great. So next up, I'll pass it back over to Dr. Eichenfield, who will introduce our next speaker and article.
Hi, everyone. I am very excited to introduce Dr. Serena Tsai. She is a pediatrician who trained in Taiwan and recently earned her Master of Medical Sciences in Clinical Investigation from Harvard Medical School. Serena has had a very productive postdoctoral research experience using big data sets to better understand a variety of pediatric topics under the mentorship of our very own Dr. Elena Harlick at Mass General Hospital. She has published very extensively on congenital nevi and atopic dermatitis, and tonight we're going to learn more about her recent publication in allergy.
Okay. Thank you so much for the introduction. And hi, everyone. Nice to meet you all. My name is Serena, and I'm a research fellow at MGH. And I'm really excited to present on behalf of our team on the work we recently published on allergy titled Evaluation of Dupilumab on the Disease Burden in Children and Adolescents with Atopic Dermatitis, a population-based cohort study. Atopic dermatitis is the most common inflammatory skin condition in kids, usually starting in babies or very young children, and sometimes lasting into adolescence or adulthood. While most cases are manageable with topical treatments, some moderate to severe cases need systemic therapies. Options include immunosuppressants, short-term systemic steroids, and biologics. Dupilumab is a human monoclonal antibody that blocks IL-4 and IL-13 and is not FDA approved for use in children as young as 6 months. It's also approved for other conditions in kids like asthma, EoE, and chronic rhinosinusitis with nasal polyps. Overall, it's a pretty safe biologic drug. The most common side effect is injection site reactions and conjunctivitis. Dupilumab has already proven its efficacy in clinical trials. Our research question is Dupilumab disease modifying for AD? When we talk about disease modification, it means that a drug can slow down or delay the disease progression or mitigate the risk of the development of related burdens. There's a good example, the disease-modifying anti-rheumatic drugs known as DMARDs. They don't just help relieve symptoms in inflammatory arthritis, but they are also capable of changing the underlying disease. So let's talk about AD burdens. So just look at this beautiful cycle. Patients with AD was associated with increased odds of mental health, allergic, infectious, autoimmune, and many other systemic comorbidities. In children with atopic dermatitis, there is an inflammatory chain reaction, well known as the atopic march. The trajectory often starts with AD and later leads to food allergies, asthma, and allergic rhinitis. So our idea is that if a drug can break this cycle early on or prevent related comorbidities, it might qualify as a disease-modifying therapy for AD. Okay, so here are some highlights in our method part. We retrieved patient data from the China X Research Network, a national database with data from multiple healthcare organizations in the US. Our inclusion criteria were patients under 18 of age with a diagnosis of atopic dermatitis coded by ICD-10 codes between April 2017 and December 2023. We chose April 2017 as the study start date because that is the time Dupilumab received FDA approval. We built our study using the target trial emulation framework, which basically allows us to mimic randomized trials using observational data. We had two groups of patients, one treated with Dupilumab and another treated with other systemic therapies, including ethoxyloprine, cyclosporine, methotrexate, mycophenolate mofetil, or systemic steroids. We then propensity score matched these groups 1-to-1. After matching, there were 3,575 patients in each group. We set the first time they got the medication as the index date. Then we follow them from the index date until the end of the study period. So this is table 1 showing baseline characteristics. All covariates were well balanced after matching, and most of them were white. The median follow-up time was 2.7 years for the dupilumab cohort and like 2.4 years for the other systemic therapy cohorts. And here are the results of our main outcomes. For starters, when doing the analysis, we excluded patients with outcomes existing before the index date. That is to say, we only counted new events. For instance, when we calculate the incidence of asthma, those patients with asthma at baseline were excluded. Infections were the exceptions, as the infections events are generally not chronic conditions. They usually occur, so it's not reasonable to exclude patients with the history of infectious events at the baseline. We found that patients on dupilumab had a lower risk of developing new onset asthma, allergic rhinitis, and urticaria, though we didn't see any difference in food allergy, allergic conjunctivitis, or allergic contact dermatitis. When it came to infections, dupilumab reduced the risk of skin infections, respiratory infections, GI infections, and urinary tract infections. We also noticed that patients treated with dupilumab had a lower risk of new onset mood disorders, anxiety, sleep disturbances, migraines, developmental delays, and ADHD. However, there wasn't a difference in risk for autism or seizures. We also did an age stratified subgroup analysis, dividing patients into 3 groups, age 0 to 5, 6 to 11, and 12 to 17. Among the age 0 to 5, those treated with dupilumab had a lower risk of asthma, allergic rhinitis, and many other AD-related comorbidities. In 6 to 11, we only observed a lower risk of asthma, but not allergic rhinitis. In 12 to 17, no significance was found. Actually, we did all outcomes same to the main analysis in our subgroup analysis, and we included them in our supplement. It appears that younger patients treated with dupilumab had a more prominent reduction in AD comorbidity risk. So to explain how dupilumab provides these benefits, we outlined several potential mechanisms. First, dupilumab may work by disrupting inflammatory cascades, which could help hold the progression of the atopic march. Second, it might also help restore epithelial barriers in the skin and airways, potentially reducing infections of these sites. Finally, dupilumab may have an indirect effect by modulating neuroinflammation, which could lower the risk of mental and neurodevelopmental problems. And it seems like earlier intervention with dupilumab could offer even greater benefits based on our subgroup analysis. And here comes the limitation. The limitations of the study include retrospective study design, potential misclassification bias due to the use of ICD-10 codes, underreporting of several comorbidities like food allergy. It is not a commonly coded condition, and a lack of longer follow-up. So we think there are a few future directions worth exploring. First, the long-term effect of dupilumab on AD burdens. Second, to confirm dupilumab as a true disease-modifying drug for AD, we need more evidence. And speaking of evidence, there's an ongoing debate about reliable biomarkers to measure treatment response in asthma. For example, IgE levels can be used in diagnosing atopic dermatitis, but its role is still controversial. Next, our study population was mostly white, so it would be helpful to know if there are any differences in response across races. Finally, we could investigate whether other biologics with similar mechanisms like tralokinumab and lebrikizumab, both targeting IL-13 and approved for children over 12, could have similar disease-modifying effects in atopic dermatitis. Thank you all for your time and attention. I would like to express my heartfelt gratitude to PJ and SBD for this incredible opportunity to share my work and the support from my mentor, Dr. Harlock. I'll be glad to take any questions.
Thank you so much for that wonderful presentation. I know that this is like a really hot topic in our land because we're so interested about whether or not we can do some type of disease modification for our very atopic patients. I guess I'll start us out. I have a couple of questions. I apologize ahead of time, and my questions are weird. So my first question is, I noticed that for the patients, like the younger patients, there was less asthma and allergic rhinitis, but not less
Yes.
food allergies. Do you think that there is something different about how food allergies develop that makes it a little different than asthma and allergic rhinitis? Or do you feel like maybe it was like it just needs more patience, like we need more power, or
Yeah, first of all, I think that the lack of like significance like in certain outcomes may be explained by I mentioned that in the studies like they are not coded in clinical settings like food allergies. It's not usually a coded condition, and another thing is like in the adolescent subgroup, this non-significance may be explained by like this atopic and allergic comorbidities might be already established in these patients at these ages. So like so I think that will like answer your questions about why we can see the difference in these outcomes.
okay.
Yeah.
So it looks one of my questions was actually looking at what future directions. It sounds like you guys have a lot of future ideas. Are there any follow-up studies that you're already planning?
Um,
Or is that a
due
secret?
to the limitation of our database, because we are using the identify really large database, so something that we can do, like we can retrieve the data about like genetics and the score of the atopic dermatitis and lots of things that we can do with this very large data set. So that I would say that this is just a preliminary idea currently like validated by our large core study, but more clinical trials are still needed to confirm them. Yeah.
I also think if we give it another 5 or 10 years and repeat the study, additional findings might tease out with time. We might see more significant results for those adolescents that weren't sensitive enough in the first few years after treatment. And it would be really neat to see for patients actually that stop treatment if there's a similar impact on their downstream atopic march.
So I guess, do you think that this type of data is starting to change how we perceive how long we keep patients on medications like dupilumab? So some people try to taper them after they've been clear for like a year, maybe two. Do you think that this is going to make us want to keep patients on the medication longer, so that we can achieve this future downstream effect?
I think that certainly is a thing that we can like persuade patients to like be on this medication for a long time and like be assuring that the effect can be less even if it is discontinued. But I would say that is another one of our limitations that we were not able to capture the exact numbers of dosage the patient received after the inject stay. So like we were not able to like build a dose response relationship. And that is also, we expect the future studies can explore more on this.
I definitely want to add that it's already helping me in my counseling of parents of very young patients who are hesitant to get started. Now we have actual data that this may impact later diseases that impact them. And it's been really powerful. So it's helped me a lot in the counseling for our youngest patients for sure.
Okay, guys, that's wonderful to hear. I'm very much looking forward to future publications in this arena. So in the interest of time, I'm going to turn it over, I think, to Dr. Mancuso.
Thank you so much, Dawn. That was wonderful. Good evening, everyone. My name is Jenny Mancuso. I'm a pediatric dermatologist at University of Michigan. And I have the pleasure tonight to introduce Dr. Marietta Papanikolaou from St. John's Institute of Dermatology. in King's College of London. We're very happy she was able to talk tonight. She actually just landed in Panama. There was a mix-up. Our email said 8:30 EST, not 20:30, and she's European, so she thought it was in the morning. So sorry. So we're very sorry about that, Dr. Papanikolaou, but we're so happy you're here. And she's going to be presenting her research letter from the JAD in July of this year titled Th2 Response Drives Itch in Dystrophic Epidermolysis Bullosa Pruriginosa, a Case Control Study. Thank you, Dr. Papanikolaou.
Hi there. Thank you so much for the introduction and the kind invitation to present my work here today. I imagine most people in the audience won't have met me before. I actually did move to the US just a few months ago to work here as a postdoctoral fellow in Miami Center alongside Professor Yosipovich. But the work I will be presenting today is work I conducted as a PhD student at King's College London under the supervision of Professor John McGrath. Can I check you can hear and see me okay first?
Yes, and yes, you're all good. Thank you.
Brilliant, thank you. So itch is a major problem in epidermolysis bullosa. Despite this, little has been published on this area. The graph you can see here on the left shows the incidence of pruritus per EB type based on a survey of 40 adult patients. And as you can see, particularly for recessive dystrophic EB and junctional EB, the incidence is comparable to that of atopic dermatitis. A more recent study published by Professor Malaria and her group showed that it was present in the preceding month in 93% of 50 individuals with recessive dystrophic EB. And this was worse in severity in the severe form of this and in pruriginosa. This was my effort to summarize evidence that has been published pertinent to leach mechanisms in all types of epidermolysis bullosa. So as you can see in the figure here, the initial event is a mechanical injury, so a separation of the epidermis and dermis, otherwise known as a blister. This stimulates the keratinocytes to produce a wealth of pro-inflammatory cytokines such as TNF-alpha, interleukin-6, and TSLP, which are subsequently released both into the circulation, but also locally at the site of injury, attracting immune cells, but also stimulating those immune cells to then produce a further series of mediators of itch and inflammation. And in the central portion here, you can see some of the key cell players, such as macrophages, eosinophils, mast cells, Th2 and Th17 lymphocytes, along with the inflammatory and itch mediators that these produce. And I'd like to draw your attention to interleukin-4 and interleukin-13 in particular. And what we know is that then these subsequently bind onto their respective receptors in sensory nerve fibers in the skin and trigger itch signals that then trouble to the central nervous system. So my particular study focused on the extremely itchy subtype of dystrophic epidermolysis bullosa, known as pruriginosa, a term coined by Professor John McGrath in this 1994 publication. And in the PRUMEC study funded by Deborah UK, this was a case controls mechanistic study of pruritus in adults with dystrophic epidermolysis bullosa pruriginosa. So we identified 69 cases of EB pruriginosa in the United Kingdom with a female to male ratio of approximately 2:1. What you can also see here is that the age of onset of pruritus and the age of diagnosis is highly variable, ranging from birth to as old as 78 years. This was the oldest patient at the age of diagnosis in our database. So amongst those, I recruited 15 individuals with a diagnosis of EB pruriginosa, along with two control groups of individuals with non-itchy dystrophic EB and healthy volunteers. History of atopy, our current evidence of atopy were an exclusion criterion for the study, and all the EB individuals had confirmed mutations in the gene encoding collagen 7. And these are some representative images of the pruriginosa cohort, where you see these rather dramatic, very typical coalescing papules and plaques, particularly on the sheens, which are the usually the predominant area affected, and very, very inflamed and highly excoriated. So we assessed pruritus severity in these individuals using two validated itch scales, the 5D and the Liven itch scale. And we went on to collect biopsies, firstly from the pruriginosa individuals, from site-matched lesional and non-lesional sites, which are color-coded here. Then site-matched lesional and non-lesional biopsies from the non-itchy EB group, and finally site-matched biopsies from the healthy individuals. We conducted bulk RNA sequencing on all those biopsies, and this is our principal component analysis plot. So for anyone who's unfamiliar with this, each dot here represents a skin sample, and these are color-coded based on whether this was lesional or non-lesional and the group it came from. And the closer these dots are along the two axes, the more comparable gene expression would be, a more similar gene expression would be between the two. And we can see that we have three separate clusters here. First, the red cluster, which represents lesional samples from pruriginosa individuals. This mixed cluster here of three colors contains normal-looking skin samples from the three groups, so itchy, EB, non-itchy EB, and healthy volunteers. And what we can see here is that these cluster together in the same area of the plot. And finally, we have this small cluster of the non-itchy lesional samples from the non-itchy EB group. And this observation was very much in line with our clinical observation that each affected lesional areas, whereas the patient's narrative was that normal looking skin was not itchy. Next, we fed our differentially expressed genes into Reactome to explore which pathways were dysregulated in lesional skin of the pruriginosa individuals. And here you can see the top dysregulated pathways. The red color represents upregulated genes, whereas the blue color is for downregulated genes. What we can see here is that interleukin-4 and interleukin-13 signaling in particular is amongst the top 5 dysregulated pathways in lesional pruriginosa skin. We also conducted correlation of the top 100 differentially expressed genes in pruriginosa lesions with the LIS, so the Liven itch scale scores of those patients. And here you can see the 12 genes with the strongest correlations, either positive or negative. As you can see, there are several genes here pertinent to inflammation, such as SOC3, interleukin-6, JAK3, but what also caught our attention here in a similar trend is that the gene encoding interleukin-4 receptor had one of the strongest positive correlations with patients' itch scores. So we went on to try and validate this finding at protein level. So we conducted immunofluorescence in those skin samples for interleukin-4, amongst others. And these are some representative images for all three groups. And indeed, what we saw here is that epidermal fluorescence of interleukin-4 was significantly increased in pruriginosa lesions compared to normal-looking skin. So in conclusion, itch in dystrophic EB pruriginosa is localized to affected lesional areas and does not affect uninvolved skin. The gene expression within those areas is distinct from that in the involved areas of skin. And Th2 cytokines, which are upregulated in those areas, might be feasible therapeutic targets to alleviate progenitor lineage. What I also forgot to mention is that, which I haven't included here in the interest of time, is that the picture for interleukin 31 this was very similar to that we saw in interleukin 4 staining. So thank you very much for your attention. Thanks to all the people that made this work possible, and I welcome any questions.
Thank you so much, Dr. Papanikolaou. That was a really interesting study. We had one question here from Dr. Eichenfield. Oh, and now it went away. It was there. Oh, okay. So she said the cytokine profile is so interesting. Did it seem like IL-6 was also elevated? Was the question.
So it was elevated at RNA level. Indeed, it was one of the differentially expressed genes. We did not stain for interleukin 6 on immunofluorescence. So I couldn't answer that at protein level.
Okay, okay. Do you have any plans for further studies related to this?
So there are several anecdotal trials, successful trials of dupilumab. So several cases or case series that have been published that show a favorable effect on pruritus. We have been trying to organize a clinical trial. It's not an easy endeavor, and I think in the context that it has been a big sort of learning experience for us too, because in the context of a rare condition, and especially a rare subtype of a rare condition, there are many challenges, and one of those is attracting funding and attracting interest from funders. And I think the second major challenge is recruiting adequate numbers of patients. As mentioned, there's just under 70 reported cases of this in the UK, and about 200 have been published in worldwide literature. So it has been a slow and painstaking process.
I was really impressed by the number of patients you had involved in this trial, actually. Yeah, that was incredible. Dr. Paller wrote that she has an ongoing trial of dupilumab, and it's going very well. With half the data in, it's looking good. So exciting news. Wonderful. Any other questions from the group? Okay. Well, that was a wonderful night. Thank you all so much for participating. And we really are grateful for all of the speakers for coming to speak and for everyone who joined in the evening. We appreciate it so much. Our next journal club will be in February. And after the journal club is over, you'll get an email from the SPD about a survey. So if everyone could please fill out the survey, we would really appreciate that. Thank you so much, everyone. Have a great night. Bye-bye.
Thank you.